I'd like to next turn to Dr. Steve Brown, who is going to be speaking with us remotely. Dr. Brown is the program director at the Banner University Medical Center Phoenix Family Medicine Residency Program and is also a faculty member at the University of Arizona College of Medicine, Phoenix Family Medicine Residency. Dr. Brown has been long involved with treatment of pain, including and public health. He was the 2014 chair of the American Academy of Family Physicians Commission of the Health of the Public and Science, and he is also an associate editor for Essential Evidence. And I'm just curious whether he can hear me and we can hear him.
I can definitely hear you. Can you hear me?
Yes, fantastic. So the floor is yours, Dr. Brown.
All right, thank you so much for inviting me to be here. Sorry that I couldn't be there with you in DC. I worked for 4 years in the Indian Health Service in rural northern Arizona prior to my current practice in an urban underserved setting. So family medicine, we take care of some of the patients that Dr. Starles talked about, but also we take care of children, which will be less of an issue for opiate-related issues, but also women's health, lots of sports and musculoskeletal, which we're going to hear from another colleague about later. So my list is on the next slide, and my methodology was less scientific than Dr. Starles. For those of you that have any experience in qualitative research, you know of the phenomenon of saturation. When I asked my colleagues, I really wasn't hearing any new answers after just a few conditions. And so if you look, the majority, my guess is 90% will come from that left side, the musculoskeletal pain, non-fracture, fracture, and the dental pain. I agree with Dr. Starles that even though opioids are used for headaches, they are not really indicated. But my guess is that the majority of the diversion, majority of the extra prescribing comes from the acute issues on the left side. Other things that people came up with, nephrolithiasis, shingles, zoster. I agree with the sickle cell issue. I think that's very important. Family doctors do maternity care, so postpartum perineal pain is another time, or post-C-section pain where it might come up. Biliary colic, we probably don't need to talk about the inpatient issues as we heard from our FDA guru. And then there are certainly times when people with chronic conditions have acute flares. So this is my list that is remarkably similar to Dr. Starles' list, even though I had a remarkably less scientific approach to finding it. So a few caveats on the next slide. So as you guys are looking at the evidence base of this, good luck. I think the thing that is so hard about the evidence base for this is that many of these conditions are self-limited. So how can you have an RCT to show that something is better than a self-limited healing of a condition? That is really hard to do. And so that's the first caveat. The second caveat is that I think the factors related to improvement of pain, like if you're deciding how many pills somebody needs, we really don't understand that healing process at all. And that I think it's mostly unrelated to medication and very likely to involve social determinants of health, like education level, poverty, work status, insurance status. It's going to be really hard to decide how many pills to give somebody for an ankle sprain because most of it is not related to things that are easy to study. And then finally, and I think you all know this, the harm of long-term opiate misuse is likely to outweigh the benefit of opiates, especially in self-limited conditions. So those are my thoughts. Thank you.